We cannot do what we do without the support of our sponsors. Our education series is brought to us by our presenting sponsor, West, and then our supporting sponsors, Daiichi-Sankyo, Merck, Lilly, and Natera. So you see, we are adding more and more. We always add more and more topics. We now have a cooking demonstration that you can jump in on. Everyone can do that for as long as you want to. And that 48 of those a year. So that's a big one, and really excited to have all of you join these events and build this community with us. So Dr. Lexi Muench is a postdoctoral fellow within the Behavioral Sleep Medicine Program and the Chronobiological and Sleep Institute of the University of Pennsylvania. I think I messed that up again.
It's okay.
Chronobiology.
We call it the CSI.
I love that. So much better.
Yeah.
So much better. Yeah. Wonderful. And then, so the Sleep Institute of the University of Pennsylvania, her work is focused in insomnia, fatigue, and cancer. Dr. Muench's work has been funded by the National Institute of Health. She also is the co-author of multiple publications in the areas of insomnia and behavioral sleep medicine, and regularly provides lectures and training on the topics. So please join me in welcoming our guest, Dr. Muench. All right, the stage is all yours.
All right. So thank you again, Sue, and the organization as a whole for having me. I'm so excited to be here. I love talking about sleep. I love working with patients diagnosed with cancer. Before I share my slides, I'll share a little bit about myself and how I got here, so you know me a little bit. So everyone can call me Lexi. I'm still not used to the doctor title. I don't know if I'll ever get used to it, but everyone can call me Lexi. I trained, I'm a clinical psychologist, and so I trained in health psychology. So I really came up working in hospitals alongside medical teams, and I developed a strong interest in working in oncology, specifically working really with breast cancer patients. And one of the things that kept coming up was that from diagnosis into survivorship and well into survivorship, patients have a hard time sleeping. And not only do they have a hard time sleeping, but cancer fatigue is a big issue. And one thing that the medical teams would say over and over is we really don't know what to do about it. And I kept thinking to myself, gosh, if this is such a huge problem, at one point I went to a lecture and the radiation oncologist had a slide that said 99% of his patients have this complaint. And I remember turning to my attending psychologist at the time and saying, if 99% of people have this issue, why are we not doing anything about it, right? In what other world would we not address this? And so I found a phenomenal mentor at Penn who works in what we call behavioral sleep medicine, who took me on, and now I'm doing my fellowship there, and my research and my clinical work really has to do with how do we help patients diagnosed with cancer sleep better? How do we help them get better sleep, quality sleep? And also, what is cancer fatigue? That I don't really have an answer for you tonight, hopefully one day, but we're really working on that area of how can we help patients have quality of life despite these, circumstances. So that's what I'm going to talk to you about tonight. And so I'll share my slide deck now. And please feel free to ask, Sue, I think you said this is okay, to stop me while we're talking. I love to have a discussion. I have to do lectures all the time, and where I have to wait till the end. So I always welcome a discussion and a conversation about this topic. So please feel free to stop me at any time.
Yeah, you got it, Lexi. We can use the chat and I will be watching that for you.
Okay, perfect. Okay, so let me just start from the beginning. Sometimes I have a hard time with the Zoom. There we go. Slideshow. All right.
Yep, got it.
There, see my slides?
Yep.
All right, so I'm going to be again talking about how having cancer doesn't mean giving up good sleep. First, I'm going to start off with a little bit of background. So let's talk about insomnia broadly. So as defined by our DSM, which is our diagnostic manual, insomnia in 2013 finally became its own diagnosis. If you can believe it, it was often considered secondary. So it wasn't considered its own thing. Now we think of it as its own disorder. And we define it as dissatisfaction with sleep that occurs at least 3 times per week for at least 3 months. It's also trouble with falling and or staying asleep or waking up too early. And what we see is about in cancer, 39% of patients endorse insomnia. It's probably a little bit more than that, but that's the statistic that I could find. And I want to stop here for a minute to talk about sleep disturbance as a whole and the idea of acute versus chronic insomnia. And so oftentimes what we see at diagnosis is what we call acute or short-term insomnia. And what that is, it's really lack of sleep when faced with a stressor. So if you think of like evolutionarily, it wasn't good to sleep when a bear was chasing you, right? And so something like a cancer diagnosis really might cause a fight or flight response. And so we see a lot of times sleep gets worse and then it recovers, but not in everybody. And so one of the things that we're trying to work on at Penn is to make sleep screening a part of the early visit so we can catch poor sleep before it becomes chronic. Now let's talk about cancer-related fatigue. A little bit harder to pin down. I often say I've picked a program of research that's like a needle in a haystack, right? Because with insomnia, it's pretty concrete. There's even objective measures. I can put you in the lab. I can hook you up. I can put EEG on your head, and I can see that your sleep is poor. But with fatigue, it's more diffuse, right? Like we've all had the flu at some point. It just feels like lack of energy. It can be conflated by sleepiness, but it's highly prevalent in cancer, and it is different than insomnia. And it's also highly prevalent in cancer survivorship, with as many as 90% of survivors being affected. It's also posited to be unaffected by rest or sleep, and that's not really evidence-based. We don't know that for sure. We're doing some research that's suggesting that if we improve sleep, fatigue also seems to improve. Did somebody have a question? I thought I heard somebody. I can't see the screen.
Nope, I did not see anything yet.
Okay.
And we can just use the chat for our questions.
Okay. So what do we know about sleep in cancer? So studies in cancer have shown that patients have longer sleep latency, meaning that it takes longer to fall asleep when compared to somebody who doesn't have a diagnosis. Increased wake after sleep onset, which means that you're more likely to be awake in the middle of the night. And also lower sleep efficiency. And sleep efficiency is how we measure, it's what it sounds like, how efficient your sleep is. So it's how much time you're spending in bed compared to your total sleep time. So we consider low sleep efficiency as anything below 85%. And so that means you're spending a lot of time in bed laying awake, which isn't good for your sleep. We also see more motor activity at night, which might have something to do with, being anemic or having low iron, but this is more common in cancer, and that can also cause sleep disruption as well. So one thing to consider is that even if you're not having a conscious awakening, these things can cause what we call sleep fragmentation. And so it's important to get these things checked at your rather regular doctor's appointment, because sleep fragmentation can make you feel really tired during the day, even if you're not aware of the awakening. Some other research has shown that during chemo, when they compare it to baseline, so before chemo, patients are significantly less alert, increased and longer daytime naps, which I'll come back to in a minute, because napping is not always a bad thing. And again, we see increased wake time in the middle of the night. So what I want to say about naps is in non-cancer populations, when we do treatment for insomnia, which I'll get to a little bit later, we often discourage napping. And the reason we discourage napping is because if I want you to sleep at night, it's not a good idea to sleep during the day. It can decrease what we call sleep pressure, which is how tired you're going to be at bedtime. However, in cancer, it's a little bit different, especially during treatment, because sleep becomes disrupted sometimes by no fault of anybody's, right? You could be doing all the right things, and because of the treatment, because of the stress, your sleep might not be as good as you would like it to be. And so napping isn't the worst thing. We know that sleep improves immune function. What we always say about naps is, if possible, try to do it in bed with an alarm. So if you're napping and you have a place where you can sleep and you have a place that you can set an alarm, that's always the best way. You don't want to nap for longer than 30 minutes because you don't want to go into a full sleep cycle, which is about 90 minutes. We don't want you to have a full, we just want to get you a little, va-va-voom. We don't want you to really go to sleep. And 20 minutes kind of, you're not in a deep enough sleep. So 30 minutes, maybe 30 to 40 is the sweet spot where you can get a little bit of rest, wake up, and then go about your day. Another thing I'll say about naps is it's never good to nap after 3 p.m. That's usually too close to bedtime for most of us. All right, so there's another interesting thing that's been coming up in the research more and more is insomnia secondary to cancer? So some of my colleagues, and this was borrowed from Dr. Nkoli Israel, have done some research where they've asked patients when their sleep difficulties began, and it showed that 67% said before cancer. Now, when that before is, I don't think they can pinpoint, but I think what they were really asking was, did you notice something was off? Anecdotally, a lot of times patients will say to me, I just didn't feel like myself, and I didn't know what was going on, and eventually the diagnosis came. 33% said after cancer, and then they followed up and said, did cancer cause or aggravate your sleep difficulties? Not surprisingly, 58% yes, 42% said no. Another caveat here is, and I'll get into this in a little bit, is that not all cancers are the same when it comes to sleep and fatigue. So what we see is breast cancer tends to have high reports of insomnia and fatigue, where prostate cancer does not. So those patients do not tend to have a lot of post-treatment fatigue. They kind of go on and they're okay. So the percentages here can also be conflated by that, depending on who they were asking. But one thing to consider is that sleep problems may be prodromal, meaning that they begin before the cancer diagnosis. And one thing we're working on is oftentimes if you're having sleep problems, you're feeling fatigued and you can't really pinpoint a life stressor or a reason, it's always good to say to the doctor, maybe some blood work would be good. Because it could mean nothing, it could mean something's going on. But usually when there's a sudden onset of tiredness, it could mean that our body is fighting something, and the work on that is ongoing. Any questions so far?
I actually have one.
Sure.
You talked about the 30 minutes. So I've heard about this, and sometimes it's like a 20, 30 minutes. Do you ever hear people actually taking like caffeine and then they go to sleep for 20 minutes and then they wake up and it's almost like this natural alarm for them?
Yeah, so that's a really great question. I was just in a talk a couple weeks ago where can't remember who the woman was off the top of my head right now, but she was a researcher and she does a lot of work with napping for government agencies, right, where they have to be alert, and maybe their shifts are long. And she talked about this thing called the nappuccino, where you have some caffeine, you take a nap for 20 to 30 minutes, and then you wake up and the caffeine is hitting you. So that's something that they're doing research on. I don't know a ton about the nappuccino. I'm not anti-caffeine though. I think that like during the day, if it's a couple cups of coffee and it's before 4 p.m., caffeine's fine. And if you want to combine it with a nap, that's fine too. There's some research that suggests it helps a lot.
Okay. It was interesting. I never tried it, but
yeah,
it seems something that, I don't know, counterintuitive,
It does seem counterintuitive, but I think it has to do with like, by the time you're done napping, the caffeine is in full effect. And so what you have is like the benefit of the nap and the benefit of the caffeine. It seems to work. And I love the name Nappuccino. So
yeah, I think a lot of us are going to be trying that one.
Yeah. Looks like we have another question in the chat before I move on to.
Yeah, so one is saying that this is saying that she's had both breast cancer and a follicular lymphoma. When I have my cancer fatigue, I sleep from 1.5 to 3 hours. Is that expected with 2 cancers?
Yeah, I think that's a good question. I don't know if it would depend, I guess, on the treatment that you got from the cancer, but it might have to do with, like I said, the treatment and also how you're sleeping and when you're sleeping. I think what I would suggest if you're sleeping that little is to maybe go for a sleep study. It might have to do with the cancer. Again, it might have to do with the treatment, the stress, how your sleep changed during the cancer and post-cancer. But that's very little sleep. But I would consult your doctor and see if there's something they can do to help you sleep a bit more.
There's another one in the chat just talking about insomnia, and it started about 6 months before her diagnosis, but she's recently started journaling, which is so such a good, tip and outcome. But she's realizing that she's not dreaming. And is that normal?
Yeah, it's totally normal. It may be that you're just not remembering your dreams. So everybody cycles through, and I'll go through this in a little bit, the stages of sleep, but there's 3 stages, and then there's REM sleep, which is different. And we usually dream in REM sleep. And if we wake up right after a REM period, we remember our dream. And if you don't, it's likely you'll forget it, but it's not abnormal to not remember your dreams. It happens.
Okay. And then another one is light sleep better than a deep sleep. And that was a question I actually wrote down. So thank you, Liz. I was thinking of that, like if you're laying in bed and it's just a light sleep, and sometimes with that mother hearing or pets or whatever else you have in the house, you can wake up so easily.
Yeah, so that's a really great question. So actually what we try to do with patients who have insomnia is get them deep sleep. And so when I'll talk more about the stages of sleep, but what happens in insomnia is oftentimes you are laying there, right? You're trying to sleep. You're engaging in what we call sleep effort, which is like a high monitoring of the fact that you're not sleeping, a lot of stress around not sleeping. And when you do that, when you're laying there, you're kind of surfing in and out of those light stages of sleep, which makes you feel worse, right? And so you're missing out on the deep sleep, which is the really restorative sleep that you need to kind of recover your immune system, feel good during the day. So the aim should be really to get that stage 3 sleep throughout the night.
Okay. And then we just had Laurie just ended up sharing that, no, she sleeps fine at night. Her naps are 1.5 to 3 hours.
Okay. Yeah. So the nap should really, so that's like that's a half of a full sleep. So I would encourage maybe 30 to 45 minutes. It's really hard though. It's easy for me to say, it's really hard to do, especially if you have fatigue combined with insomnia. And so what I would suggest is if you need to split your naps up throughout the day, that would probably be better than doing it in a lump.
And even though she's sleeping well at night, at least 8 hours.
Yeah. So sometimes, I don't know about her course of treatment or her history, but when some of my patients are having to go through more intense treatments, we recommend napping because they're so tired and they often sleep fine at night. It's one of the few places in the work that we do in cancer where we'll recommend naps.
Okay. All right. Thank you, Lexi.
Sure. All right. So I'm now going to talk about mechanisms. So why is all of this happening? So let's talk about cancer-related fatigue and what causes cancer-related fatigue. There's so many things that can contribute to cause and maintain this phenomena, which makes it super hard to study. So the first thing that I'm going to talk about is physiological factors, which means when you get diagnosed with cancer, there can be pain. I think I alluded to anemia before. You have possibly insomnia just from the stress, right, of the diagnosis and everything you have to do. And I always say that life doesn't stop when you get diagnosed. So it's not like you get diagnosed and everything stops. The world keeps going. You might still have work, kids, family, all of this on top of having a cancer diagnosis. So all of this can contribute and make anybody feel fatigued. The other thing we have is chronobiological factors. And what I mean by that is your circadian rhythm. And so your circadian rhythm, there's 2 processes when it comes to sleep. You have your sleep, which is like hunger, right? As the day goes on, you start to get more tired and then hopefully you go to sleep at night. And then you have this circadian piece, which wakes you up. It tells you if it's day or night. It's your internal clock. What happens in cancer sometimes is that internal clock gets all messed up. It can happen because of insomnia, but there's some research to suggest now that it happens because of treatment, and that radiation treatment can cause a shift in your circadian pattern. So that can also happen and make it hard to feel like you can go to sleep at night, and it can also lead to fatigue. The other thing is psychological factors. I don't want to minimize this because it's often hard to tell the difference between fatigue and depression, right? And anxiety can also lead to fatigue. And so these things are really important to manage and address if you can, because that can also help mitigate some of the fatigue that you may feel. Cancer type and stage. So I think I talked about this before, right? That cancer type and what stage you're at can, can kind of dictate how your fatigue is going to be. So patients diagnosed with prostate cancer do not have a ton of fatigue. Breast cancer patients, head and neck patients often have the most fatigue. So it really depends, and it's important to pay attention to and ask your doctor about too when it comes to treatment. What's my quality of life going to be? What are other patients? What have they experienced? Right. I always encourage my patients to be their own best advocate in asking these questions about how treatment is going to impact their life, and especially when it comes to fatigue, because it can be so debilitating. The iatrogenic effects of treatment. And what that means is really how treatment affects you, right? We've talked about course of treatment and how different treatments can cause more fatigue or less fatigue, or can even cause insomnia. Again, talking to your doc if you're in treatment or going to be receiving treatment about how is this going to impact me? How fatigued am I going to get? What does the research show? What have your other patients experienced? What are you doing to combat fatigue? So all of these things together can really be a recipe for fatigue and even insomnia. And the other thing is sociocultural factors, right? So what's going on at home? What's going on in your social life? What other, factors might be impacting fatigue? So all of these things, again, combined can lead to increased fatigue and are important to pay attention to.
Yeah, Dr. Muench, we have someone, and Lucia was just talking about that she's gotten some insomnia, and it sort of goes along with, some of the factors that you listed here, that it usually occurred with her when she had surgery. So
Yeah.
in the beginning, she had it, and then now she had a second lumpectomy, and she's having it again, but she just doesn't have it any other time. During radiation too, she sleeps a lot. And, we hear that all the time. I mean, you're exhausted, and
Yeah.
I've always been known if your body wants to sleep, like it probably needs it. And I don't know if that is, are you saying that, yeah, if she's sleeping 4 to 5 hours during the day and then 8 hours at night, her body is talking to her and saying you need this during this treatment time and it's short-lived?
Yeah, I think so. I mean, this is like, again, in my non-cancer patients, I would never suggest this, but in cancer, yeah, I do think, especially during treatment, if your body is saying you need to lay down and rest, yes, listen to your body, again, within reason. And we don't want to make, one of the things that happens I was speaking about your circadian rhythm earlier, that happens when you start napping a lot during the day is your body starts getting used to napping during the day. So I would say once treatment is over and you're starting to feel more pep, it's important to kind of break that cycle and not nap during the day. But if during treatment, kind of just like, when you have the flu, if your body needs to sleep, I would recommend sleeping, but trying not to do so all in one sitting, and trying to keep active too, if you can. There's a slide on this later, but one of the things that's really recommended to mitigate fatigue is exercise. And that doesn't have to be like a full spin class, right? But it can just be like taking a walk around the block, stuff like that. Sunlight is really important for what they call entraining the circadian rhythm, which means getting your circadian rhythm back to like a normal rhythm, for lack of a better word. And so if it gets lost with all the napping and the treatment and that, diagnosis of cancer, one way to get it back on track is to get some light.
Yeah, I heard that study too. It was actually from one of our systems chief of radiation oncology, and Dr. Lee was talking about if there was a study in the Journal of Medicine that if you end up walking light exercise 20 minutes before radiation and 20 minutes after, that the exhaustion level decreases. And it's that movement, that like you said, exercise is nothing crazy. It's just movement. It could be a yoga, it could be a Tai Chi, it could be a walking, it could be whatever you want it to be, but you're just moving that time before and after, and it just eliminates some of the exhaustion.
It's so helpful, especially if you can do it outside. One of the things we used to do when I was on rotation at one of the cancer hospitals was if my patient was ambulatory, we would do our sessions walking, and then the place where I worked had like a beautiful garden, and I made sure to get them outside because I wanted them to get sunlight. And I also wanted to get them moving. So that's it seems simple. Sometimes it's harder, right? Sometimes if your body is saying, I just need to lay down, do that. However, it's always good to like get up and get out, especially like after treatment. You're totally right, Sue.
Yeah. All right, we have another question coming up, and this is
Sure.
about just fatigue, depression, anxiety. It disappears 15 minutes into acupuncture because she's taken acupuncture for her anxiety, but then it creeps back up hours later. She's taken tamoxifen, and can that contribute to cause the fatigue?
Yeah, I think treatments like tamoxifen can definitely increase fatigue. I just want to make sure I understand the question. Is that so the acupuncture helps the fatigue, and then it's creeping back up
Hours later.
Hours later, yeah. I mean, I also think that fatigue, although this research is ongoing, is probably connected to our circadian rhythm. So what might be happening is that you're getting the acupuncture, it's making you feel better. And then depending on the time of day, you might be experiencing some sleepiness because of the time of day. I would honestly track when the fatigue is happening throughout the day, because that might have something to do with it as well. Or if it's related to, your stress level. I think it's always good to track. A lot of my patients who are dealing with fatigue track it, so we can identify when it's the worst, so we can kind of have a plan.
She also wanted to know how long should she wait until she saw somebody, an expert like you. I think those are good points. We heard about acupuncture last night, and it is true. If you do your acupuncture at night and you get a certain needle, opening up that channel, it causes drowsiness. Like you'll be fatigued. So I think understanding when the acupuncture is may have a little bit of play in there, but she has some anxiety, some depression, like all the normal symptoms from a cancer diagnosis.
Yeah, totally. So I think it's always best when you start noticing these things, especially when it comes to sleep, nip it in the bud right away, right? So if you can find a provider like myself who does behavioral treatment, or even if you go to your PCP and say, listen, I'm really not sleeping well. I do behavioral treatments for insomnia, but I'm not anti-medication. Unfortunately, we don't have a ton of psychologists and people who do the behavioral work in insomnia yet. So depending on where you live, that might not be accessible. But what is accessible sometimes is sleep medication. And oftentimes for like acute short-term insomnias, that does the trick. And then you start feeling better and you get the rest that you need, and then you can come off the med. So I think it's always best to address these things, whether it be sleep or anxiety or depression, right away, so they don't snowball and get worse.
Great. Thank you, Lexi.
Yeah, sure. Any other questions, or can I keep going?
Keep going. Yeah.
Okay. All right. So let's talk about some tips for better sleep. All right. So I think I had said I'm going to go through the sleep stages. So this is what we call sleep architecture. And what you're seeing here is what we call a hypnogram. And this is what comes after you get what they call a polysomnograph. They often do it for sleep apnea. You go into the lab, they hook you up. Maybe some of you have gotten these before. And this really shows the stages of sleep. And so what you see here is this line at the top is awake. And then you go down into stage 1. And then you go into stage 2 and stage 3, and then you go down to stage 4. I will say that there used to be 4 stages. Now they've combined it into 3, but 3 and 4 are the deep sleep for our purposes. And then you kind of come back up, out, and then you have a REM, and then maybe you'll wake up for a little bit of time. It's common, even the best sleeper will wake up sometimes. Everybody wakes up a couple of times per night, sometimes not even realizing it. And then maybe you wake up and you go back down, you wake up, you go back down. And what you'll see here is that your REM stages get longer throughout towards the end of the night. So this person looks like they woke up around 7, maybe late in bed, but their REM stages, these purple things, got longer throughout towards the end of the night, So you have a lot of your deep sleep in the first half of the night, and then you have your REM in the latter stages of the night. Here. All right, so let's talk about how much time we spend in each stage. So stage 1 is what I like to call, this isn't a research term, dad sleep. And the reason I call it dad sleep is because it's a kind of sleep where you don't really know you're sleeping. My dad does this a lot. He falls asleep in the chair and I wake him up, or my sister wakes him up and then he says, I wasn't sleeping. And you spend about 10% of your time there. It's really light. It's not restorative. It's just the early stages of sleep. The waves, if you were to look at this on an EEG, if you were to look at your brain waves, they almost looks like you're awake. Stage 2 is 60% of our time. We spend a lot of time in stage 2. One thing I will say about stage 2 is we do not know a lot about it. there isn't a ton of understanding of what happens there. But what's really interesting about stage 2 is if you're looking at the output in the lab, they have these things called sleep spindles and K complexes. And that's how you know somebody is in stage 2. And we spend a lot of time there. Some people think that stage 2 prepares us for the deeper stages of sleep. Some researchers think it has to do with REM. But regardless, we spend a lot of our night here. And then we have stage 3 and 4. We spend about 10% of our time here. And this is the deep stage of sleep, the stage of sleep that you really need to feel, good during the day. This is really important. And what happens in insomnia and fragmented sleep, so in cancer, we do see a lot of fragmented sleep. It was interesting. I ran a study recently, and we were noticing this, that while our patients seem to sleep okay based on the objective data, it was fragmented. It wasn't consolidated. And what happens there is you miss out on this deep sleep. And then we have our REM sleep. So stages 1 through 4 are considered non-REM, and REM, which is rapid eye movement sleep, is where we typically dream. You can dream in your stage 3 and 4 sleep. However, the dreams that we really remember, where it's vivid and maybe you're sitting at a table with like a monkey playing checkers, is our REM sleep. It's important, they think, for memory consolidation. You lose REM sleep as you get older. And so we spend about 20% of our time there. Again, most of the time being in the latter stages of the night.
Okay, a couple more questions in the chat. So one is, are we able to talk about CBD and THC rather than a medicine? Do you have any experience there?
Oh yeah, sure. So there's not a ton of research in the sleep world on this because it just, it's been hard to study up until recently. And so I can't speak to the science on it. I will say that, like, anecdotally, the patients that I've worked with in the cancer clinics do much better on it than standard sleep meds, or even when it comes to pain. I prefer when patients are on taking THC. I think it's much better for quality of life purposes.
We actually are doing a whole speaker series on medical marijuana. So that's coming up in April again,
Awesome.
And a couple. So so please tune in, and you'll be able to hear a little bit more about that.
Yeah, I'm an advocate. I think when I see patients who are on, especially some of the harsher drugs like the opioids and the opiates and some of the harsher sleep meds, I think for acute short-term use, it's fine. I don't love it for long-term use. I think it causes, sometimes opioids and opiates can mess with the immune system. And the last thing you need when you're coming off treatment or going through treatment is to have anything, messing with your immune system. So I'm an advocate of THC and CBD. I don't know as much about CBD.
Yeah, great.
Yeah. All right. So how much sleep does one need? So I get asked this question almost every day, multiple times a day. And one thing I will tell you is I want to try to shift everyone's focus to how many hours am I getting, from how many hours I'm getting, to what is the quality of sleep that I'm getting, right? Quality over quantity, because I would much rather that a patient get a really good 6 hours than a really fragmented 8. And so right now the population mode, meaning like most people in the US are getting about 7.5 hours. Which is fine. We typically need between 6 and 8. There is a subset of people who we call short sleepers. They're very rare. They can exist on like 5 to 6. I've yet to meet somebody like that, but they exist, says the research. So the population mode is 7.5, but I really want you all to focus on how do you feel the next day. If you get a really good solid 6 versus, again, the 8, that's what matters more. That's what should matter more. But alas, this question persists in our culture. How much sleep do you need? And another, like, a little tidbit, it's down. The population mode is down from 100 years ago. It used to be 9 hours. But also what happened 100 years ago is I think people slept like early in the evening, then woke up, had dinner, and then went back to sleep. So we were kind of diurnal there. All right, so let's talk about sleep needs, sleep ability, and sleep opportunity. These are the 3 things that are really important when it comes to thinking about our sleep. Sleep need being how much sleep do you actually need personally? Sleep ability, how much sleep can you actually get? And sleep opportunity, how much time do you actually have allotted, right? We see this problem a lot in our adolescents where sleep opportunity is limited because they have to get up for school early in the morning, but they need a lot of sleep. Adolescents need a ton of sleep. So it's important to try to align these things if you can. It's not always reasonable, but if you can, if you're feeling, if we spoke about this earlier, that your sleep need is high, you're not feeling good, you've had treatment, listen to your body, right? However, your ability might only be 7 hours. So just know if you're napping during the day, that might impact your sleep at night because your body's ability is only 7 hours. And giving yourself the opportunity to sleep, right? Self-care, very important. We talk a lot about it, but I always worry that we don't live it, right? And so really listening to yourself, listening to your needs, expressing your needs, and making sure you're giving yourself enough time to sleep. All right, and this is just another schematic showing this, right? So in insomnia, this could be true for cancer-related fatigue too. In efficient sleep, ability, opportunity, and need are all kind of aligned, but in insomnia, ability is small, need is high, and opportunity is large, because oftentimes what happens in insomnia is we're trying to get more sleep. And another thing I encourage you to think about is ask any good sleeper in your life what they do to go to sleep, and they look at you like you're crazy. I don't do anything to go to sleep. I just put my head down. So there's not a lot of trying to sleep, and here sleep opportunity is indicating that in insomnia, we're often trying, we're engaging in a lot of effort to go to sleep.
Dr. Muench, is magnesium good for sleep?
I'm not quite sure about that one. I mean, I don't think it would hurt. I think it's probably good if you're having, sometimes like when it comes to vitamin deficiencies, especially in cancer, like with all the treatment, it's not a bad idea. So it wouldn't hurt. That's for sure. All right. So these are some of the things that have worked for cancer-related fatigue. So we talked about exercise. This D just means an effect size. And what that means is in the research, it's just showing how effective this is. 1 is really effective, 0.5 is in the middle, and 0 is not really that effective. We consider 0.3 moderate. So exercise is helpful when it comes to cancer-related fatigue. I always like to give a shout out to our friends our researchers in the MS world, because they've really done a phenomenal job in moving the fatigue work forward. So they do a lot of work in the exercise realm. Medication, not so much. There's some stimulants that have been tried for cancer-related fatigue. They really don't work that well, but stay tuned. I'm part of some work that's trying to figure out if there's a medication that can help with this, combined with our behavioral interventions that can take the edge off a little bit, but not quite yet. We haven't quite figured that out yet. CBT for insomnia, which is cognitive behavioral therapy for insomnia. Cognitive behavioral therapies were originally developed for depression. And they've been extended now to almost everything: anxiety, eating, insomnia. Works well for fatigue, better for insomnia, but again, we're testing that right now. We think that patients who have high levels of fatigue might need a higher dose of the treatment, dose meaning number of sessions. So behavioral treatments also seem to work. And here's some more info on CBT-I. It's 6 to 8 sessions. Sessions are between 30 to 45 minutes each. The latter sessions are usually a lot shorter. We work on behavioral, cognitive, and psychoeducational interventions, meaning that a lot of chronic insomnia, not the short-term acute insomnia, comes out of behaviors. So spending a lot of time in bed awake, pairing the bed with wakefulness, lack of standard bedtimes and wake times. So we work with the patient to fix those things. And it's also the first-line treatment endorsed by the American Academy of Sleep Medicine and the American College of Physicians. So if you have a CBT-I provider near you, I highly encourage going if you're having sleep problems. It's a really quick treatment. It's so effective. We can't say enough good things about it. And this is just a schematic to show how CBT-I works and acute versus chronic insomnia. So what you'll see here is you have a premorbid state where you don't quite have insomnia yet, you're not above the threshold, and then something happens, like a cancer diagnosis. And so you start to develop acute or short-term insomnia. And what you see with this bar here is some precipitating factor, which again could be the cancer diagnosis, which causes you not to sleep due to stress. And then we have this early phase which is this kind of in between chronic and short-term insomnia. Most people go back to sleeping well after the stressor has resolved, but some people don't. And part of the reason some people don't, about 10% of the population, is because of these perpetuating factors. And again, the perpetuating, maintaining factors for chronic insomnia are staying in bed when you're not sleeping, tossing and turning, engaging in a lot of stress and thoughts around sleep. The best thing to do when you can't sleep is to get out of bed and don't go back to bed till you're sleepy. And if you feel like you're maybe not going to sleep that night, it really is okay. Most people do fine the next day with one night bad sleep, and it means a higher likelihood that you'll be really tired and sleep the next night. If I give any advice tonight, it will be, if you're not sleeping, just get out of bed and go to another room. And then we have chronic insomnia. And so what you see here is it's less of the stressor, so the acute short-term stressor, it's more of the maintaining, perpetuating factors that are now keeping the insomnia there. So that's how chronic insomnia comes to be.
Okay, a couple more questions, Dr.
Sure.
So a couple things just about what to try. And, of course, THC is coming up, and I know that there's a lot of good data behind that.
Yeah.
Melatonin, how about that one?
Oh gosh, this is a tricky one. So melatonin is what we call a chronobiotic. And so we make melatonin ourselves in our brain, endogenously. So a couple hours before bedtime, your brain starts making melatonin as a sign that it's getting dark. So it's like a light dark hormone, really. It's fine at low doses. The problem with melatonin is oftentimes here in the States, they sell it at kind of high doses in the hospital, and it can have effects on, I think it's progesterone. I'd have to double check that, but it has effects on your hormones. And I always say for my adolescent female patients, my patients going through like breast, ovarian, cervical cancers, where there's a lot of like hormonal changes, maybe you're on tamoxifen, it's probably not a good idea. Especially if it's anything over like 2 milligrams. It can really have a detrimental effect over time. So if it's helping you and you're taking it at a low dose, I think it's fine. But it's often not used or prescribed the way it should be. If you're going to take it, you should take it like 2 to 3 hours before you go to bed. That way it onsets with your own melatonin.
Okay.
Yeah.
And then we have Sheila had asked, she exercises every day, and she falls asleep, but she's waking up during the night for hours.
Yeah.
Can you actually get too much exercise?
Yeah, I mean, I think you can overdo it. I wouldn't recommend like exercising strenuously right before bed. A little bit of exercise before bed is actually a good thing, along with a hot shower, because it raises your body temperature and then it like drops it down really quick, which helps you go to sleep. But yeah, I don't know if you can there's always like over exercising, but as long as you're not doing it before bed, you're fine. One thing I'll say about being awake in the middle of the night is what I would recommend to her is to get out of bed. So if you're not getting out of bed, make sure that when you're awake in the middle of the night, you're out of bed. And when you wake up in the morning, don't sleep in. So keep consistent bed and wake times, and that should kind of help you resolve the problem.
So when you wake up, don't hang out in bed.
Don't hang out in bed, get up. So as soon as you notice that you're awake and you're aware that you're awake, you should get out of bed and go to another room. If you can't go to another room, it's also okay to like go sit in a chair or somewhere in your own bedroom. It's fine if you want to like watch a TV show in another room or be on your phone. The blue light, it's okay. Because what's going to matter more is that you become more tired and eventually you go back into the bedroom and go to sleep.
Yeah. How about yoga before sleep?
I think yoga is fine. I mean, I think it's fine. It's relaxing as long as it's not, I wouldn't recommend like a intense like Bikram or like hot yoga class. But I think a little bit of yoga, I often do Peloton yoga before sleep. I think that's a great idea.
I do too. And then Susan was just saying that she tries everything. The only thing that works for her is a 0.5 of a 0.5 Ativan. And she's, she knows it's probably not the best thing for her, but I know I've heard, sleep is, I wish we could write a prescription for sleep, because that is so important that you can, find a way to get that.
Yeah.
So
Totally.
how do you feel about this? Because I hate for her to feel like she's doing something wrong.
No, I don't think you're doing something wrong. If it's helping you sleep and you're doing it in conjunction with your doctor, I think it's totally okay.
And then the last one was, what's a really good sleep position?
That's a good question. I think it depends on the person. Like some people are back sleepers, some people are side sleepers. I think it really depends on you and how you sleep most comfortably. Like my 5-year-old stepson sleeps upside down. He seems to make it work. So I think it just depends on the person.
And there's no like right side, left side because of the heart and lifting up.
No, I don't think there's any science to back that up. None that I know of, at least.
Okay. All right. I think we got them all.
Okay. All right. So I was just talking about this a minute ago, but the behavioral model. So if you don't know Pavlov's dogs, I'll review it very quickly. He paired food with a tuning fork, and then eventually over time, what happened was the dog started to salivate just the tuning fork and didn't need the food. And we conceptualize sleep in this way in the bedroom. And the reason I was just saying get out of bed is because over time with chronic insomnia, the bed becomes paired with wakefulness. And so it becomes a cue for wakefulness. And so a lot of people say, I can fall asleep on the couch. When I go into the bedroom, I'm like wide awake. And part of that is because it's become now, again, a cue for wakefulness. So that's why we also say get out of the bed when you're awake to unpair that. So we want it to be bed, sleep, bed, sleep, bed, sleep. And then finally, what is good stimulus control? So when we talk about stimulus control, we talk about the stimulus being the bedroom. We want to control it and make it a place for sleep. So the only thing you should be doing in the bedroom is sleep and sex. Odds are 1 and 2 that you will fall asleep. Stimulus discontrol is eating in bed, reading in bed, watching TV in bed, worrying in bed, working in bed, cleaning the bedroom. I could go on and on. So what we really encourage is, if you can, it's not easy, to make the bedroom a place for sleep. And I think that's all I have before I go on to talk about my study. Can answer more questions.
Yeah, I told you this. I love this slide because I know, my husband and I will read and sleep, or we'll play with the dogs, right? Like, or read in bed, or we'll play with the dogs. And I never thought I'd be one of those people that would have my dogs at the foot of my bed. Here I am now. And that is a problem. It is such a problem that I'm up, because of their movement. And it just, I just love this slide. I just felt like it really does set boundaries. It's almost like when you have children again, and you're really trying to get them into a routine,
right?
Forget about that for yourself.
Yeah. And it's hard to do, again, like even in my non-cancer patients that I see, right? Like, this is sleep is a problem, and it's always something that we're trying to achieve and master. I don't know if anybody's ever seen that Lunesta commercial with the butterfly. SNL did a bit about this. If you look it up, it's really funny. He's like chasing the butterfly and ends up falling out the window, right? Because he's like chasing sleep. I show this sometimes when I give lectures, that you can't really catch sleep. And so the best thing to do instead of trying to sleep is to just give up and go in the other room. And you'll find that it's a lot less stressful, and you'll fall asleep eventually.
Yeah, I love that tip. And get out of bed, just get out of bed.
Just get out of bed. It's the best thing to do when you can't sleep, just get up. And it's hard, I always like whenever, and so in the second session of the behavioral treatment I do is when I work with the patient to set the bedtime and the wake time. And patients will say to me, like, I got this. And I said, I know you say that now, but when you're cozy in your bed and it's 2 a.m. and your brain's offline, the first thing it's going to tell you is Dr. Muench is crazy. Because that's what happens. So it's like easy to say, it's hard to do. So I just want to say to anybody on this call who's battling insomnia and struggling with insomnia, just know, I know how hard it is, and it's easy for me to sit here and say, you got this, but it can be done, and you can start to manage your sleep again.
Yeah. And we certainly don't want to feel like we're doing everything wrong. Like all of us can look at this and go, oh gosh, right?
Exactly.
My husband has to read in order to go to sleep. And I had somebody else say that in the chat as well. But then he's reading on his phone. So that blue light is so strong. And I can see that light. I can see it. It's unbelievable how much that wakes me up. Yeah. And I'm turned over the other way. So do you have any feedback on the blue light?
Yeah, I mean, so in terms of like insomnia and treatment, I usually don't, just not to do it in bed, I think is what I would say. It's okay in like when I'm weighing, like I need somebody to be awake in the middle of the night, as long as patients are going to the other room and doing it or not doing it in bed, I'm fine with it. I wouldn't consume a ton of blue light before bed, but again, I'm usually weighing the cost and benefit of, if you're going to be up, usually what'll happen is you'll get so tired, it's not going to mess with your circadian rhythm, because that's the concern about blue light, is that's going to shift your circadian rhythm. So with patients with insomnia, it's not super concerning. However, if it's bothering you, like if Sue, I was treating you, said your husband was in bed and it was bothering you, I would probably ask him to put it down or go into another room, because it's keeping you awake.
Yeah, no, I totally do that, or
Yeah.
not totally, but but he has to read in bed in order to sleep. And I guess that's
Sure.
the things that you're like, well, let's try and get rid of that. Like get
Yeah.
up, read on the chair, and then come back over.
Sure.
How about reading a paperback book versus an ebook?
In bed.
Oh, is
So,
it Sarok? Is that how you say your name, Sarok? Saroj? One of our members had asked.
oh yeah. So
Yes,
in
in
bed,
bed,
I would
yeah.
I would say not in bed. So if you don't have insomnia, here's what I'll say. If you don't have insomnia and you're not at risk for insomnia, it's probably okay to occasionally read an ebook or a book in bed. Like I could sleep standing up at any time. I often joke that I'm still recovering. Like I'm 4 years out of my doctoral program, but I'm still so tired of recovering. And so I could sleep anywhere, anytime. However, if you, for example, like I said earlier, have recently been diagnosed with cancer and you're feeling stressed, like that's the time that I would say to a patient, if I met them in the hospital, do not read in bed, because you're setting yourself up for pairing the bed with worry and wakefulness and all of these things. So it depends on the situation. However, good stimulus control is to just do it out of bed, and you can read an ebook. Again, it's not enough blue light to mess up your circadian rhythm. Unless you are like a shift worker, somebody who works at night, and you were coming to see me because I had to get you on a day schedule, then I would say to you, don't read at night. But for most of us, it's totally fine. Blue light is not a concern. It's not as big of a concern I think the media has made it out to be.
Okay. Okay, good to know. All right, I think I got them all.
All right, so I have one more slide. So we're actually doing a study at the University of Pennsylvania where we're looking at the association between cognitive behavioral therapy for insomnia, which I just talked about, dose meaning number of sessions, sleep duration, and fatigue in patients who have a history, this should say history of breast cancer. We're looking for patients who have completed treatment. And we're going to evaluate how low and high dose number of sessions, CBT-I, affects sleep efficiency, sleep duration, and cancer-related fatigue in subjects who had diagnosis of breast cancer. We're going to randomize, so patients will be placed into different conditions. And then we're going to measure this with sleep diaries, which means you'll fill out information about your sleep, Fitbits, and weekly questionnaires. And so if you're interested, my email is going to be on the next slide. I also think Sue's going to send out a brochure. Reach out to me. We can see some patients nationally. I think there's about 20 states right now because of licensing guidelines that we can see patients in. And so just reach out to me, let me know. And if we can see you, we can do have a discussion about the study and whether or not you're eligible. And if you're not eligible, I can try to see if I can hook you up with somebody in your state with a provider, so you're not left without treatment. So I just wanted to put in a plug for that because we are doing this study, and yeah, and I think that's all I have. And here's my contact information. Feel free to reach out with any questions, or if you have any questions after the talk too. I'm always willing to talk about sleep any time of day. Well, maybe not bedtime.
And not in bed.
Not in bed. You're right.
That was great. We do have a couple more questions. So there was one that, and if you want to unshare your screen, that way we can see.
Oh, sure.
So one was, what about meditation in bed? And I'm like, oh my gosh, that sounds amazing, because meditation is not easy to do, right?
No,
So how do you feel about that?
Yeah, so this is a good question because it's a tricky one. So here's what I'll say. If you don't have a sleep problem and you're meditating in bed, like sometimes I'll do the Peloton meditations in bed if I'm feeling anxious, but again, don't have a sleep problem. What happens with insomnia and meditating is it quickly turns into worrying and sleep effort and anxiety around sleep. So like I'll have patients be like, yeah, I was like meditating, and then all of a sudden, before I realized it, I was like really worked up that I wasn't falling asleep. Like the meditation didn't work. And that's when I say to them, like, okay, we need to like meditate out of bed. Like you can worry all you want on the couch. binging a Netflix show, just please don't do it in the bedroom, because that is a recipe for disaster when it comes to insomnia. Insomnia will go on forever in perpetuity.
Yeah, such good points. It seems like a little bit of a common sense, but we just don't put the two together sometimes.
Yeah, I also think, again, you're working like in the middle of the night. My mentor, my teacher, Dr. Michael Perlis, who runs our program, has a saying that I think is so true. It's bad to be awake when reason sleeps. And what that means is in the middle of the night, your decision-making parts of your brain just are offline. Like it's not there. And so it seems reasonable, but in the middle of the night, you're working on like purely biology, and your brain is going to tell you to do whatever it is you need to do to go to bed.
So there was one Dane was saying that doesn't quite understand because there's specific sleep meditations. So I guess there's a variety. How would you answer that one?
Yeah, that's a great question. So again, I don't think sleep meditations are bad. I think this is all good. I mean, I think even like I went on like what I call my melatonin soapbox. I even think melatonin can be good when used correctly. I think what has happened in sleep is it's a really hot topic and there's a lot of misinformation out there. And so I think all of these things can be good, but sometimes what happens is they're just not used in the right space. And so for somebody with chronic insomnia who's worrying in bed, the last thing I want to do is place them in bed with a meditation that probably isn't going to work. And they're probably going to be stressed when they like end the meditation and they're not sleeping. What I prefer they do is just get out of bed. And if they want to do the meditation somewhere else, that's okay. But I don't want to increase their frustration. For someone who sleeps well, I think Peloton meditations, Calm app, whatever meditation you use can be a beautiful thing, because anything paired with sleep can make you sleep. Like sometimes like I have a best friend who like has paired Seinfeld with sleep, and all she has to do is like turn on Seinfeld and she's out. But she's not worrying about sleep, right? Like she hears Jerry Seinfeld and she's donezo. Like, so, if you don't have a sleep problem, you go ahead and you're good to go.
And I think what you're saying, and correct me if I'm wrong, is that you're just saying don't do it in bed. Do it.
Just don't do it in bed. And
do it somewhere else. And then you're doing this meditation. It's lovely. It's getting you tired. And then as soon as you crawl in that bed, it's changing that habit. That's how I'm sort of seeing this.
Yeah, totally. And
it's not like don't do it before bed, just don't do it in the bed.
Don't do it in bed. And also, if you don't have insomnia, if this isn't a problem for you, I want to be clear about this. If you don't have insomnia and you listen to a meditation every night, or you fall asleep to Jerry Seinfeld and it's working for you, don't stop doing it. That's fine. This is really for people who are at risk for insomnia. So I'm talking about the people who are stressed right now and who maybe are noticing sleep, like bad sleep coming, or people who have chronic insomnia. We don't want those people doing it. I mean, Dr. Perlis, he jokes he's been reading the same book for 30 years because it makes him fall asleep. Like he reads the same book every night and never gets past like the 50th page. So we all have the things that we do. It's just for those at risk for insomnia or those with chronic insomnia, we really just don't want those things happening in the bedroom.
Got it.
Yeah.
And then is it better to take a Benadryl than a sleeping pill?
Oh, that's a good question. What kind of sleeping pill? This could be a talk on its own. This could be a separate talk. I mean, I think like a Benadryl can induce sleepiness. I think it depends on the sleeping pill. How I feel about medication is if it's working for you and you're not having side effects and you feel like you can function during the day, be my guest. Oftentimes what I see though is patients come into my office and the sleeping pill hasn't worked for them in 5 years, but they're so nervous to come off it. And it's not benefiting them anymore in the way it did maybe like early on, like Ambien's guilty of this. It works initially and then it's kind of stops working. And so I think if the pill is working for you, it's fine. And my follow-up would be what other sleep there's so many. They all have different pros and cons.